Hi, everyone. My name is Brianna Mazzucaro, and today I'm going to be presenting on impaired olfaction is associated with cognitive decline and neurodegeneration in the brain. So to get us started, some background that I think is essential to understanding the research article. The DSM defines dementia as substantial cognitive impairment that interferes with the ability to perform everyday tasks independently, and a subtype of dementia that you're probably all familiar with is Alzheimer's. And dementia has a prevalence rate of 13.9 in individuals over 65 years of age, which worldwide in 2018 ended up affecting 46.8 million people. So this is not a small disease. It reaches all ends of the world and really has a huge effect on people. And that number is actually predicted to increase to 115.4 million by 2050. So it is just really growing. And there is currently no cure for this. And it is really hard to research because a lot of the signs and symptoms of dementia are also the signs and symptoms associated with just normal aging. So there is a really big need to get to know this disease more and study risk factors and predictors so that early intervention can be done and affect these people who are at risk. So one risk factor that people have been researching over the past few years is olfaction, because we know that olfaction receptors decline with age. And recent studies suggest a relationship between impaired olfactory function and risk of cognitive impairment, such as dementia. So again, neuroimaging studies also support that lower olfactory function was associated with smaller hippocampal volume in patients with mild Alzheimer's, but not in cognitively normal individuals. So while these two studies support the idea that maybe olfactory impairment can be a predictor of dementia, there are studies that show mixed results where some show that they did predict that impairment and some did not. So there is a need for more research to establish the relationship between the olfactory impairment and dementia, which is kind of what this study sets out to do. They had two main goals, which was to investigate the longitudinal association between olfactory impairment and cognitive decline, and then also to explore the association between olfactory impairment and neurodegenerative markers using structural MRI. So the methods they used to investigate those two main goals involve the Rush Memory Aging Project, which is an ongoing study that investigates risk factors for common neurodegenerative diseases in adults. And using that project, participants were recruited from the greater Chicago area from senior citizen housing facilities, church groups, and retirement communities. And it's important to note here that the participants were all volunteers, they were not recruited. So the study was held from 1997 to 2014 with annual follow-ups for 15 years. The analytic sample was 380 participants with the mean age of 78, and they were 76% female. They also did employ some exclusions to the sample, which were previous diagnosis of Parkinson's disease, dementia, or that they were missing the original odor identification test. So this is an image directly from the research report, just showing you that they did start with 1,919 participants, but only 420 underwent the MRI scan, which was imperative for this specific study as they wanted to investigate the relationship between brain matter volumes and aging. So we ended up with an analytic sample of 380. Using that sample, the BSIT was used to test odor identification, which the BSIT is a standardized test with 4 alternative choice measures. So basically just a multiple choice where participants were presented with a booklet with micro-encapsulated odorants that when scratched releases an odor. So basically just a scratch and sniff. Once they scratched it, they would smell it and then were asked to identify which of the 4 options the odor most closely resembled. After they completed the test, they were given a score of 0 to 12. Anything 6 or less would be considered anosmia, which is having no smell. Then hyposmia would be for men 6 to 10, or for women a score of 6 to 10.25. And then normal olfaction was categorized as for men a score of 10.25 to 12, or for women 10.5 to 12. And then they wanted to assess cognitive function. So it was assessed at entry level and then followed up annually. They used 21 performance tests, which typically took about an hour. And those tests ranged from episodic memory, perceptual speed, visuospatial ability, semantic memory, and working memory, which gave them a clear picture of the cognitive function going on. They also did take into consideration things such as smoking history, alcohol use, education, and socioeconomic status. They also excluded dementia patients, as I said in the exclusion criteria, and they used the definition and the criteria established by the National Institute of Neurological and Communicative Disorders and Stroke and Alzheimer's Disease-Related Disorders Association. Then for the brain MRIs to compare the brain matter, the brain volumes, they used a high-resolution MRI scanner to get these data images. And with those images, they collected data that was whole brain gray matter volume, cortical volume, and subcortical volume of gray matter. And then the total volumes of both left and right hemispheres were calculated. It's also important to note that 19 participants were scanned at a different site. Therefore, the site of scanning was used as a covariate, but it was controlled for an analysis and did not make too much of a difference. So here's the result of the BSIT scores. You can see that hyposmia was the leading population with 56.1%, and normal olfaction received 36.3%, and anosmia, which is complete loss of smell, was 7.6%. Now to go into a little more detail about the results of this experiment. Participants with impaired olfaction were older and had lower global cognitive function, and higher BSIT scores were associated with higher cognitive function and slower decline. Higher BSIT scores were also associated with greater volumes of hippocampus, entorhinal cortex, amygdala, fusiform gyrus, temporal pole, and inferior temporal complex. Patients with olfactory impairment had lower volumes in all of those categories as well. So some strengths and weaknesses of the research. The assessment of cognitive function in multiple domains was really important because they didn't just test one specific type of memory or one specific type of ability. They really tried to touch on all factors, which leveled the playing field, and they were also all previously proven methods of testing cognitive ability, which is important. They also repeated yearly follow-ups for an extended period of time, and by using this longitudinal approach, it gave a better insight as to what was happening. It wasn't just one data collection. They did it so many times for that reason. They also removed incident dementia, which is important to rule out that the olfactory impairment was driven by previously established dementia. And they also had a very high survival rate of participants, which increased the internal validity. Only 99 people ended up dying, which is sad, but it is low considering the sample size. But there's also some important limitations to think about before we accept the results as the conclusions. They used cross-sectional MRIs, which does present an issue as brain changes typically occur before the cognitive decline appears. So the cognitive decline might actually be from brain abnormalities instead of, the dementia. It's also important to note that they did use a psychometrically established measure of odor identification, but it is discriminative. It was super brief, and it only was identifying the odor, which we know olfaction is more than just odor identification. It was also short, so maybe it didn't give a really true picture of what was going on. Also, they were not able to exclude people with allergies, which, when you're dealing with allergies, especially seasonal, it is really hard to breathe. And that definitely could affect your sense of smell, causing you to score lower on the BSIT, but not necessarily because your olfaction was impaired. And finally, as we touched in the beginning, participants were all volunteers, which took away the random selection. They were all well educated from one area, so it's difficult to apply these results to the entire population when the sample size was so specific. Taking all of that into consideration, this study demonstrated that olfactory impairment was associated with faster cognitive decline and lower volume in the fusiform gyrus and middle temporal cortex, including the hippocampus and entorhinal cortex over 15 years. This study suggests that olfactory impairment could be a predictor for cognitive decline, an indicator of neurodegeneration, but it's a predictor rather than a marker of already present dementia. So this could be used for early intervention, but it wouldn't be able to be used as a diagnostic tool. And while previous studies have done similar research using a shorter follow-up time, have shown similar results, it's still necessary to continue this research over even longer periods of time with the advancements of even more neuroimaging and even more rigorous cognitive testing until we can really accept this as something that is true. And here are the references I used to create today's PowerPoint. Thank you guys all for listening, and I hope you enjoyed it.